So for the talk we give tomorrow, so tomorrow Philippe Moreau from Nantes, a colleague of mine from Nantes, was supposed to address two things. The number one is a debate with Joseph Michael from US. The US have access to a lot of drugs, which, and I'm speaking as a European, and is more about almost like toys for kids. If you have the money, you can buy more toys. If you don't have enough money, you just buy a limited number of toys. But then the question is how you play with your toys smartly altogether. So that's the US. And so the US have this kind of vision that for a number of patients, we are very close from being able to say, okay, you have an ultra good risk, let's say prognostic, and you're gonna turn MRD negative, or you have a chance to turn MRD negative, and possibly you'll never relapse. Or possibly you relapse in 15, 17 years, and if you are diagnosed at 70 years old, 85, 87, we'll see. So what Joseph Michael will address in the debate is should we pull all in drugs for cure? And he will. So it makes sense for him to address this, because again he comes from the US, where technically speaking, if you have a good insurance or a lot of money, you could really address the question and challenge your physician, saying, well, you know, I have plenty of money, I'm ultra rich, just give me 4 drugs and cure my myeloma. And can you cure my myeloma with 4 drugs? Or can you cure my myeloma with all these emerging new therapies that Hermann Insele, Professor Menose from Würzburg, Germany, will talk about in the end of the afternoon, CAR T cells, BiTE, etc. On the other hand, Philippe Moreau, and so I will debate with Joseph Michael on well, guess what? There is no point in trying to cure myeloma with an all-in drug approach. Let's consider that what makes the survival of the patient, it's not just one line, but it's in fact a repeated number of lines of therapy. And then 5 + 5 + 5 makes 15 years. And we are more likely today in 2019 to take patients to 15 years in 3 lines than in only 1, all in. So I'll be debating, and I'll be talking about and showing proof that in 2019, it's a bit of a dream to think that all in is feasible, all in is manageable, cost-wise, side effect-wise, etc. And all in will take you to 15 years. While it seems to us that it's more reasonable to accept in 2019 that a number of lines, ideally 2 or 3, I'm not talking about 7 or 8, but ideally 2 or 3 will take you to 15 years free of death and free of myeloma issues, so you could have like a reasonable quality of life, a not too costly approach, and still living with your cancer in a reasonable state and shape in life. So that's for the debate in the early morning. And then there is a round of workshops organized for a smaller group to be able to cover numbers of issues, including renal issues, including the type of treatments, which is a workshop that Philippe was supposed to cover with actually Joseph Michael, and that I will take over with Joseph Michael, a number of workshops on an issue that we are start facing worldwide. We've learned that a number of drugs we were using in the relapse setting actually work much better if we use them upfront. And the best example is these days lenalidomide. So lenalidomide is a first-in-class immunomodulator drug, Revlimid, and we've been using lenalidomide in the relapse setting for like years, since 2005 in clinical trials and 2008 approved in Europe. But more recently, it was approved upfront and with great benefit to the patients. But we've also discovered that if the patient relapses while on lenalidomide, so what we call refractory, as opposed to exposed but not refractory, the subsequent lines of therapy could be affected by this status. And that being naive or exposed to lenalidomide versus being refractory to lenalidomide is a totally different story when it comes to the next line of therapy. And there is a number of data now that from clinical trials where patients were recruited either naive exposed or refractory, showing that the lenalidomide refractory patients tends to do much poorly, even in a certain extent, similarly to high-risk myeloma, almost as if being refractory to lenalidomide upfront could be associated to some high-risk feature. So we will, Joseph and I, we will go through a series of demonstrations that we are at the verge of being able to demonstrate that being len refractory, being exposed to len upfront is a great thing, but becoming len refractory may alter the way you treat the patient in the relapse. And once we've said that, then what are the options for the physicians and for the patients and their families? And this is where we are in trouble because most of the approved studies that have been leading to drug approved, daratumumab, first in class on the CD38, but also all the proteasome inhibitors, bortezomib, carfilzomib, and ixazomib, all these drugs have been approved with Revlimid. But if you are len refractory, you're not going to use this combination because it makes no sense. So you need new combination, non-len lenalidomide, so you could propose options to the patients. Some of them will be pomalidomide, another immunomodulator drug from the same family but different mechanism of action. Some of them will be non-pomalidomide based, and so we'll cover this tomorrow morning in our workshop.